Hi everybody, I'm Professor Paul Lee. I'm a consultant orthopedic surgeon, have a specialist interest in regenerative medicine and cell therapy. I'm also a visiting professor of sport medicine in University of Lincoln. Tonight we're going to talk about the magic of fat cells. So here are some of the learning points we're going to talk about today. Why are we interested in fat? What do we know about the stem cells pathway? What are perivascular cells? Is these fat cells treatment effective? Are all stem cell treatment the same? So hopefully after my lecture tonight, you will have some understanding of how fat cells treatment work, and you can make up your own mind about the clinical evidence and is it going to be effective. So first of all, I would like to talk about osteoarthritis. Because we are talking a knee guru, of course, we're going to focus in the knee. Osteoarthritis is a degenerative condition of the joint. It's an extremely complex process. These can cause by many different factors. Swelling and inflammation are the result of osteoarthritis, often not the cause. And you can see some of these x-ray here. There is two knees side by side, and there's a normal x-ray on the right, and which is the right knee, which is here, and then the abnormal one, which is the left knee, which is here. So you can see on the x-ray there are some features that we can see. So this first one here is narrowing of joint space, and you can see this clear difference between them. And the other thing is osteophyte. You can see this bit of bone here is the osteophyte. Next feature is subchondral cyst, which is a cyst within the bone. And then the next features and final features is the increase of bone turnover. We call that subchondral sclerosis. And of course, the alignment between the two legs is very different. So overall, arthritis is a mechanical issue, as well as there is a chemical element within that. And we'll explore that in the next few slides. So you may often hear about wear and tear of arthritis. So what is wear and tear? So I put some bike tires here. You can see this is a brand new tires. You got all the tracks and it looks very nice. And then there is when the times go on, when you start using it, the tires wear out. So you can see there's mechanical changes between the tires. Now, we are not just we are not a dead material. We are a living creatures. So we are alive, and we got biological cells within us. And with the tires, it doesn't get repaired. But within our own body, our knee have ability to repair itself. Osteoarthritis is not simply just a mechanical problem and a wear and tear issue. As a matter of fact, the molecular pathway within the osteoarthritis is extremely complex. So this is just a simple diagram to show the cell pathway and cell signaling pathway of how arthritis, how we believe arthritis occurred. And you can see there's many different cells involved, and there are many signaling molecules within the cells. It's very difficult to identify what is the one key factors that's caused osteoarthritis. Nevertheless, we need to think of how we're going to tackle this problem, because osteoarthritis around the knee is a very common problem. So I would like to talk about the Leo principle of regenerative medicine when we're looking at cell therapy. This is a principle that based on 4 key factors. Mechanical factors, we talk about the wear and tear. We talk about the cells. We talk about the scaffold, which is the seed of where the cells are supposed to sit in. And also we talk about the environmental factors, which are the cytokines. Now tonight, we're going to just focus on one topic, which is the cells within the osteoarthritis environment. Of course, the other 3 factors are extremely important. So let's talk about cells. Where can we get cells from in the human body? So these cells have to be spare. For example, we can't get cells from an essential part of our body. For example, we can't get it from our brain. We can't get it from a beating heart as such. So where can we find any spare tissue that potentially we can use for some cell therapy? Some people get cells from skin. We can get cells from blood. And perhaps maybe from the bone marrow. Some of you might have heard of bone marrow stem cells. Or we can get it from the placenta, umbilical cord, or even from the embryo. But that is very controversial. And let's not forget, we can also get cells from fat. So of course, there are so many different ways we can get cells. Where is the best way to get it, and which cells will perform better? So here, let's explore the stem cell pathway of which stem cell will turn into what organ or what tissues. So look at this. These are different cell type. Generally, depends on what we want to do. We can get the cells from different type of stem cell line. Of course, the most powerful with the most potential is the embryonic stem cells. But embryonic stem cells, there are different rules within different countries, and I don't think it's entirely ethical to just take cells away from embryo. So I'm not going to talk about that. What we're going to talk about is just going to be adult stem cells. And in adult stem cells, we typically split it into two groups. One is what we call hematopoietic stem cells, which are this group of cells. And the other group of cells is called mesenchymal stem cells, which are these type of cells. Now, it's very clearly that from the hematopoietic stem cells, these cells are coming from blood. And of course, they will turn into blood product. For example, red blood cell, white blood cell, or platelet. And everything else from our body is coming from a cell called the mesenchymal stem cells. These cells will turn into chondrocyte, osteocyte, fibroblast, adipocyte, skin, muscle, or nerves. Let's take a closer look with the mesenchymal cell pathway. As you can see from the top of the mesenchymal cell pathway, they slowly develop and they become mature and will form into different type of cells. You can see from the very beginning, they all look very similar. As when they get mature, they look very, very, very different. As you can see here on a muscle cell, they got a nucleus in the middle, and there is some long, thin muscle fiber. As comparing to a fat cells, they look completely different. Now, these cells, when they differentiate and develop into a specialized cells, they don't tend to go back to form stem cells. As you can see, they are very, very different. So tonight we're going to talk about fat. So why fat? Why do we think fat is good? And is it really a cell therapy? Is it really a stem cell therapy? So I think it's a very interesting Chinese wisdom. Fat people always seem to be a bit happy. And you can see my happy fat Buddha. Now, let's talk a little bit about the cell biology of the anatomy of an adipocyte, which is fat cells. You can see within the fat cells, there is a nucleus, and there is Golgi apparatus, and there's mitochondria. So what are these components within the cell does? In the nucleus, you can think of it as a control center. The Golgi apparatus, you can think of it as the workers, and the mitochondria, you can think about it as a power plant. So these cells will, if they want to create anything, they will ask the nucleus will send some signal to the Golgi apparatus to make some molecules that help the cell communicate and help the cell to move, help the cell to develop. The more important thing within the fat cell is the most of it is contained in here is fat. And then, of course, there's a cell membrane around it, and that is the anatomy of a fat cell. If you look at it on a scan electron microscopy, this is what a fat cells look like. Now, you can see the nucleus here, and maybe some mitochondria here. And most of these guys here are the fat. Does it look like a stem cell to you? So, if it doesn't, and we know that these fat cells don't tend to move back to form stem cells and go down to the other pathway to form cartilage or bone, so why do we think putting fat cells into arthritic joint is a good idea? Does it make any logical sense? So the trick is this: we need to look at fat in a slightly different way. When we look at fat, we shouldn't just look at fat in a cell in isolation. A fat, we need to see it as an organ. Within the organ of the cell, there are more than just the fat cells, and that is what we're really interested in. You can see this diagram here to show the within the fat, and there is different molecules at different cells within there. The key cells that we're interested within this fat is the pericyte. And you can see the pericyte is a cell set around the vessels. The fat is inside the body, have a lot of microcapillaries. It's got very, very rich blood supply. And within these blood supply, there's blood vessels. And within this blood vessel, there's these cells. And of course, there will be some what we call adipocyte-derived stem cells that floating around, but there's not going to be that many of those. But the key cells we're after is the pericyte. Here is a scan electron microscopy photo of a pericyte. You can see these red structures around there. They are the cells of interest. And this is a blood vessel going around there. This is the cross-section of a microcapillary. And you can see the bit I highlighted green here is the endothelial cells, which is the cells that is aligning the capillary. In the center, marked where this, say, E, is the lumen of the capillary. So where the blood flowing through. At that particular time, one red blood cell is trying to pass this vessel. Now, you can see the big thing around the outside. That is the pericyte. And that cell looks very much like the stem cell that we saw before. So this is the big nucleus that we can see. And with this, we believe there is some potential that it can help regeneration. So this is the a pathway that we think that a pericyte can go down. Usually after some injury within the blood vessel, the pericyte will break free from the blood vessel, and then it form a mesenchymal stem cell, and then it become activated, and then they have some medicinal property within that cells. Would that cell actually move all the way back and turn into the cells that we want it to turn into? I think that depends on many other factors. Remember the slides that I showed you before, we need to, based on the 4 things, we need to make sure the environment is correct, the chemical and mechanical stimulation is also correct before any cell can turn into the cells that we desire to go down. But nevertheless, these perivascular cells have great medicinal use, and they have great regenerative potential. So this is a slide that we have looked at a different type of cells that we can get from the body, and they have different type of colony forming unit potential. And you can see within the lipoaspirate, within the fat cells, within the fat harvest, we have actually a lot higher, a lot more colony forming unit within those within the lipoaspirate, compared to bone marrow aspirate and even amniotic fluid. So medicinal stem cells, MSC, what does it really do? As I alluded on earlier on, does it really turn into cartilage in the knee and help repair? It might, given the right environment, right mechanical loading. It can potentially turn itself into cartilage cells and it start repairing. But however, I think the more important role for these cells, they are signaling molecules. They are signaling cells. These cells enter an environment and then they take control, they release factors, they actually guide whatever cells left over within the environment. For example, if you got knee arthritis, you still have some cells, some cartilage cells within the knee joint. When we inject or when we put in this medicinal stem cell within the knee, they will start releasing molecule, and these molecule could help signaling the cartilage to start to rebuild the environment. I think in order for these MSC to turn themselves directly into cartilage cell and start building, I think we need to do more investigation and more study to confirm this direct effect. But for sure, they will give out signaling molecules, signaling pathway to help the local cell to repair the environment. So let's look at the let's look at the literature and see what literature say about this fat cell treatment and fat cell injection. So this is one of the paper that had been published by my Italian colleague. On this is just a simple one single case series of MRI scan to show the MRI scan on the cross section here. You can see there is a increased signal here, here, and here you can see a damage of the cartilage. And they have said after 12 months treatment of the fat cell injection, you can see the difference of of the affecting area. On this person, they have show in their paper that their Oxford knee score, is something that we use to assess how the patient's doing within the knee pain. They have jumped from 32 to 47 at 12 months. And in their paper, it claimed that at 30 months, the patient go back to full activity and skiing. Now, within this MRI scan, we can see there is increased bone turn, increased signal within the cartilage, and there is a layer of substance that has formed. If you look at this one here compared to this one, there's clearly a gap there, and there's something have happened there. Now, this is just one single case report that's back in 2016, so you may say that, well, that could just be luck. Okay, then let's look at further studies. So this is a study published by a group from Croatia and also a group from America. So in this study, there is 32 knees that was injected with these fat cells. What this group have looked at is the pain score at rest and pain score at movement, as well as C-reactive protein. Now, C-reactive protein is a very sensitive molecule within our body. If there's any inflammation around our body, the C-reactive protein will go up. The normal level, as you can see here, initial M0 at beginning of the treatment before injection of the fats, is 6.54. So the average, the normal range is about 10 to 15 roughly. So anything below 15 is great, it's normal. The lower it is, the better, the less information there is, the higher there is. If you, for example, you have an infection or inflammation, they can go to 100, sometimes 200. Now the interesting thing is that here, after 6 months after the injection, they have checked the C-reactive protein, and the 12 months they check the C-reactive protein as well. This number has not gone up significantly. If anything, you can see has gone down slightly, which means, however, these changes is not statistically significant. So we could say that there's no change in the C-reactive protein, which means that the fat injection does not give any inflammatory response. The next very interesting thing that I want to show you is the visual analog scale. Visual analog scale is how a patient rates how much pain they have within the knee. 10 being the most severe, 0 being painless. So they have done it in a patient that is resting, and after that, they ask them when they move around, how much pain do you get? Before treatment, it's about 4 when they rest, and then after treatment, at 3-month follow-up, this number half. And you can see when they move, during movement, during activity, again at the beginning is 7. They rate themselves 7, and after treatment at 3 months, they think the pain score is half. And this pain score had continued to stay low, continue to improve and continue to stay low. At 12 months follow-up, the pain score is very low compared to what happened initially. And these figures are statistically significant all the way along. So what does that actually mean? Is that fat injection does not cause an inflammatory response, and it can help patients improve the pain. And in this study has demonstrated that at 12 months, the pain relief is still maintained, and, and it is significantly different. Another really interesting thing that they have done within this study is to look at the proteoglycan content within the cartilage with a special MRI scan called the dynamic scan. Within this scan, they can actually pick out the proteoglycan content. The higher the proteoglycan content, the better the quality of this cartilage is. So in this study, they have concluded that there is a significant increase in these proteoglycan content, which means that the quality within the cartilage, within the knee, has significantly increased after the injection. Now remember, this study is based on 32 knees. So you may say that, okay, that's quite useful, for me as a patient. I don't want to be out of pain. How about for the doctors, because the doctor, they tend to just measure a little bit more than just pain. Have you got any more study? And, is there any further evidence? So there's another study I have found with this fat injection. And this is an Italian study by Dr. Russo. And with this, we are looking at different scoring system within orthopedics. Now, the first line that I want to show you is the Lisham score. With the Lisham score is talk about how it's usually be used to measure how active or how for soft tissue injury, and sometimes we use this for measurement of how active people are after the ACL surgery. You can see the graph here to show T0 was before the treatment and T12 is 12 months after the treatment of fat injection. You can see the Lisham score has improved on average 31 points, which is a significant jump. And of course, we also look at visual analog scale. This, and you can see before and after on here. Beforehand, it was high up here, so which patient got more pain. Afterwards, the average score is lower, is almost half. So therefore, on this occasion, on visual analog scale, the lower is better. So the visual analog scale in this study have improved by 24 points. Next thing to look at is IKDC, another very complex score that used by knee surgeons to look at how the knee does. And again, on this one, the higher the score, the better. And you can see before and after, it has a big significant change. And finally, we look at the KOOS, which is, again, have shown significant difference and significant change between them. Now, in this study is, again, based on 30 patients, 1 year follow-up, and the results are very, very good. So you may say that, okay, fine, you got some clinical data on the knees. Does it work on any other joint, or does it only just work on knees? Now, my understanding is that a knee joint is a synovial joint. If a treatment work in one joint, that is in one synovial joint, it should work in another synovial joint. If it doesn't, then we should worry about it and think about that. Is it actually the treatment's working? So I therefore go look for further literature in terms of does it work on any other joint? And I found this very interesting study. And this study has shown that with people that have shoulder arthritis, with 20 patients, they have shoulder arthritis either within the glenohumeral joint or the acromioclavicular joint, with or without rotator cuff tear. And on here, they have actually looked at the pain score. You can see they have, instead of labeling it VAS, visual analog scale, they call it the NPS, which is the same thing. The high, which is a visual analog scale, the higher the score, the more painful the patient have. You can see before the treatment is up here, and after the treatment is almost half. And this effect has maintained within the study period. And then, of course, as doctors, we look at the different types, different score as well. The most obvious scores to use is the American Shoulder and Elbow Surgeon score. And you can see pre to post-op, again, is a very big jump. And this jump has maintained throughout the year. So, as you can see through here, this fat injection worked on knees, also worked on shoulders. They are both synovial joint, and surely they have some effect and some chemical effect amongst the joints itself, and it is why it has some effect to help patients to improve the pain. So the next question is, are all fat cell treatment the same? Do we just take some fat out and put it into patients' knees or shoulder, and then it will work all the time? Of course it doesn't. Of course it doesn't work that way, because remember, the science and the logic behind this fat cell treatment is not about the fat itself. It's all about how we process that fat and how we break the fat down, and how can we potentially release these perivascular cells. So this is one of the ways that we do them. We take some fats out from the tummy, and then we got the fat tissue. We separate them, and then we do a field washing to get rid of the molecules that we don't want. We want to get rid of the red blood cell for certain, because that is an irritant to the body, and certainly we don't want to put that into the joint, and it will, because if we put that in, it will cause inflammation. And in some labs, we sometimes use sonification. We put ultrasound to break those fat down and to potentially release these parasites. And then after that, we may use centrifugation, and then we process the fat. And of course, with that, with appropriate environment, appropriate culture, appropriate stimulant, we can start growing cells. So the processing technique is extremely important with the fat cells. Now this is I just want to show you here a difference in a simple just decanting a fat within the syringe, and also there is a commercially available kit that you can just separate the fat. There is many different kits out there, and each of them claim they do different things. But the very important thing is the operator needs to understand why we're doing these steps and how each step can influence the cell's viability, and actually can we release those perivascular cells. Now, to me, by just leaving the fat decanting on its own, we wouldn't release anything. We just separate them into different layers. By processing them through a centrifugation with a bit of a gel to separate the fat, that might help to purify a little bit, but does it actually release those cells? It's unclear. So there are many different methods, and I think in order to release these fats, we may have to use a more mechanical method. And there are different devices out there, different techniques out there they all have their different advantage and disadvantage. But this talk is not about that. This talk is about what are we looking for within the fat. The cells within the fat are, just to recap, adipocyte, which is the fat cell itself, the actual fat, and there will be some adipose divide stem cells, and the most important thing, the pericyte, and of course you got your blood vessel, and we got the extracellular matrix, which is the bit that join everything together. Now, I must say that the importance about the processing method. You can see this is the diagram to show that if we process the fat cells inappropriately, we end up breaking the fat cells. When the fat release from the cell from the actual adipocyte, it may not be very good for the joint, because these liquid fat could become an irritant to the joint itself. So therefore, the processing method is extremely important. And finally, to answer my initial title of The Magic of Fat Cells, the science within the magic is the perivascular cells. And that's the end of my presentation. I would like to dedicate my presentation to Professor James Richardson from Oswestry, who is a very good teacher of mine, a mentor, and also a leader in regenerative medicine. Thank you.